Okay. Good morning. My name is Dr. Khayathi Koganti, and today I'm going to do my presentation on topic chronic inflammatory demyelinating polyneuropathy. So what is CIDP? CIDP is a chronic inflammatory demyelinating polyneuropathy, which is an acquired immune-mediated neuropathy characterized by either progressive or relapsing remitting course of disease characterized by systemic weakness of proximal and distal muscles. History. The first case was described by Eric Horst Burns in 1890, and it was before a part of Guillain-Barré syndrome, which was separated in 1958 by Austin, based on its progression, like prolonged duration, relapsing remitting course, enlargement of nerves, and responsiveness to corticosteroids. Epidemiology. The prevalence of CIDP, it ranges from 0.7 to 10.3 cases per 100,000 people. As you can see, it's more in United States as like 8.9 cases per 100,000 people, while it is less in Japan as it's 1.6 cases per 100,000 people. So it's more predominantly seen in males with sex ratio ranging between 1.5 to 4. And it primarily affects adults, and the disease incidence rises with age, and median age of onset is not that well established. So etiology, it's mostly idiopathic, but sometimes the variants are associated with other disease processes like Waldestorm macroglobulinemia, monoclonal gammopathy of undetermined significance, HIV infections, chronic diabetes. Pathogenesis. Usually, it is the disease cause is not well known, but there are some evidences which shows that it has immunological basis of both humoral and cell-mediated type. Humoral being like T cell activation, and it's activated T cell crossing the blood-brain barrier, and activation of cytokines, interleukins, interferons. And humoral immunity is mostly characterized by deposition of immunoglobulins and complement proteins in myelinated nerve sheets. Okay, and pathogenesis, like neuropathological findings, it's mostly as it is on microscope, transverse section of microscopes, you can see remyelinating, demyelinating in form of onion bulb formation. This image is showing us the biopsy of sural nerve and brachial nerve plexus of same patient, where we can see demyelination and onion bulb formation in slide image A, and there is like marked hypertrophic changes in slide B of brachial plexus. Like on transverse electron microscopic, we can see there is macrophage mediated demyelination, which is indicated by letter M, and thinly remyelinated axons in slide D. CIDP is also associated with, its variants are also associated with antibodies in various regions like nodes of Ranvier. The most characteristic antibodies found are neurofascin 186, neurofascin 140, contactin 1, and contactin associated protein 1. These are IgG4 kind of type of antibodies. Having these antibody positive CIDP are not of typical disease course. They are different, and it's like treatment process or treatment also varies with normal typical CIDP patient. Clinical features of CIDP. Wait, it clinical features again varies depending upon like the type of patient we have. Like usually the typical CIDP, most of the patients are of typical kind, which is slowly progressive. And there are some cases of relapsing remittive type of progression, which is most commonly seen in younger patients. The weakness is on both proximal and distal muscles, and it's mostly seen in both upper and lower limbs. The proximal muscle weakness can be characterized by difficulty in walking, difficulty in raising, combing of hair, on raising the hands. And distal muscle weakness is characterized by foot drop, unable to walk, and even doing fine movements. So tremors are seen in some patients. Most of the patients have absent reflexes, and there is also sensory impairment in both proximal and distal, but it is more predominant in distal muscles. And the sensory impairment is more predominant in vibration, decrease in vibration and position sense when compared to pain and temperature, indicating it is affecting the large myelinated sensory fibers. Patients also have painful dysesthesias, and autonomic symptoms are not that common when compared to other things. There are some variants of CIDP which are classified by European Academy, which are multifocal, focal, pure motor, pure sensory, distal and sensory predominant, and proximal. Multifocal CIDP, it is also known as Lewis-Summer syndrome, and it is seen in 5 to 10% of CIDP patients. It is asymmetrical when compared to typical CIDP, where it is symmetrical, and it is multifocal. And it is characterized by autonomic symptoms, neuropathic pain, and its cranial nerve involvement. And we can see in electrodiagnostic studies that it has conduction block. Focal involvement is mostly seen in brachial plexus and lumbosacral plexus. Pure motor, it is more, the symptoms are predominantly like most all motor symptoms, like including all motor nerves, including the motor cranial nerves. Electrodiagnostic studies show motor involvement and do not show any sensory involvement. Likewise, pure sensory, they have it involves large fiber sensory nerves, causing balance problems, pain, paresthesias, dystesias. They do not have any clinical weaknesses or autonomic dysfunction, and electrodiagnostic study does not involve any motor activity. There is another type called as distal and sensory predominant. It is length dependent, symmetrical sensory and sensory motor dysfunction, which is more commonly seen in lower extremities. If it happens in upper extremities, it usually happens in the late course of duration, and it spares like trunk and face. Usually, this distal and sensory predominant type of CIDP, it's commonly associated with Waldenstone macroglobulinemia and monoclonal. It's mostly involved with Waldenstone macroglobulinemia, and in that case, there is positive anti-MAG antibodies, MAG antibodies. So if that associated with monoclonal IgM, it is different from CIDP as it is resistant to standard immunomodulatory therapies. And distal sensory predominant without any like anti-MAG antibodies. It is a type of CIDP and it is responsive with like usual immunomodulatory therapies. Proximal variant of CIDP. If this if the inflammatory demyelination is more predominant in the sensory nerve roots, it is called as proximal type. It is characterized by symmetric sensory ataxia, vibration proprioceptive deficits, and it spares the this variant spares the peripheral nerve peripheral myelin nerves distal to nerve roots, which is characterized by sensory and motor nerve conduction studies being normal. This type can be diagnosed on MRI by showing enlarged and enhancing nerve roots and abnormal somatosensory evoke potentials and elevated CSF protein. Neurofascin antibody-mediated variant, it's mostly seen in younger patients where sensory ataxia and tremors are more commonly presented. This type is not responsive to IVIG and it is responsive with B-cell depletion therapy like rituximab. Contacting antibody-mediated, it is also more severe. It is often severe and predominantly motor involvement with and it is associated with nephrotic syndrome, and the treatment is similar to that of neurofascin antibody mediated. It is more responsive with B-cell depletion therapy. Differential diagnosis. As this CIDP is most commonly wrongly diagnosed, so we should look into the differential diagnosis in order to rule out other associated diseases. So one of them most commonly being acute inflammatory demyelinating polyneuropathy. It is differentiated from CIDP, it is acute in onset as the AIDP reaches its end stage usually within 3 to 2 weeks, but it does not reach beyond 8 weeks. Well, CIDP has the disease progression, like minimum disease progression is 8 weeks. AIDP is monophasic, but it can have relapses up to 2 times within the 8 weeks of disease onset, whereas CIDP has multiple relapses. AIDP is characterized by the involvement of any other disease processes earlier, like antecedent events like previous history of vaccination, infection, or any surgeries 3 to 4 weeks before the disease onset. And it is 70% of cases are characterized by the previous events, whereas in CIDP or like the antecedent events are just 30%. It is AIDP is have more cranial nerve involvement, and the need of ventilation is more because it progresses towards the respiratory muscles, whereas CIDP does not have the need. AIDP has more autonomic symptoms like hypertension, heart rhythm disorders, and gastrointestinal dysmotility, but CIDP doesn't have that severe of autonomic involvement. Other demyelinating neuropathies that need to be ruled out are multifocal motor neuropathy, distal acquired demyelinating symmetrical neuropathy with monoclonal IgM gammopathy, and anti-MAG. Chronic ataxic neuropathy with ophthalmoplegia, IgM paraproteins, cold agglutinins, diazolyl antibodies, POEM syndrome, and demyelinating neuropathies associated with medications such as TNF alpha blockers and checkpoint inhibitors. There are some genetic mimics in of CIPD that we need to rule out before diagnosing the patient has CIDP, like Charcot-Marie tooth disease, hereditary neuropathy with lability to pressure palsies. These both are characterized by the conduction block, and transthyretin familial amyloid neuropathy is also one of the genetic mimics that we need to look for. Diagnostic evaluation. Usually when the patient first comes, the things we need to look for are, is this the disease progressive type or relapsing remitting type? If the patient has any weaknesses or sensory deficits. On examination, we need to look for areflexia. Electrodiagnostic testing is one of the important things we need to look for in order to diagnose the person with CIDP. The characteristic features are partial conduction block, conduction velocity slowing with prolonged distal motor latencies, delay or disappearance of F waves, temporal dispersion, and distance-dependent reduction of compound motor action potential amplitude. There is like a criteria, electrodiagnostic criteria that we need to look for, which is in the attachment here, which is on lab evaluation. We need to rule out the associated diseases. Like there is no specific thing to specific lab test to point out to CIDP. It is mostly done to rule out other like associated diseases. Lumbar puncture, it is the most characteristic finding in lumbar puncture is albuminocytological dissociation. Like if the CSF protein is increased more than 45 and CSF white count is normal, then the person is diagnosed with, it is one of the criteria where the person is positive for CIDP. There are some other conditions, like if the person is diabetic, as the CSF protein is usually high, we need to look for the CSF protein to be more than 100 in order for them to be diagnosed with CIDP. Even like the patients with age more than 50, we need to look for CSF protein threshold for more than 60 in order to rule in or rule out CIDP. Neuroimaging, MRI is one of the gold standard things to look for, which shows enlarged and enhancing nerves. And it can also be used to as a guide for like abnormal for nerve biopsies. And it is usually done in atypical cases. So this imaging shows in like it shows typical CIDP condition where it is symmetrically involved, symmetrically enlarged nerves of the brachial plexus. Whereas in image B, we can see that it is not asymmetrical and it is like enlarged in one side and it is not that enlarged in the other side. Nerve biopsy. Nerve biopsy is usually done when all the other studies are failed to establish the diagnosis of CIDP. Like if the electrodiagnostic criteria is not met, or if it is associated with other disease processes or vasculitic processes. The characteristic features which can be seen in nerve biopsy are endoneural edema, onion bulb formation, macrophage associated demyelination, demyelinating and demyelinating nerve fibers, and inhomogeneous involvement of different fascicles and different areas within same fascicle. So this is the nerve biopsy section showing onion bulb formation. And on slide B, you can see that it is like it is the focal neuropathy of median nerve. And slide C, it is mixed pattern showing acquired which is most common in acquired neuropathies. The diagnostic criteria, European Neurological Association and Peripheral Nerve, they made a diagnostic criteria for the patients to be diagnosed with CIDP, which says like clinical inclusion criteria, which is like symmetrical proximal distal weaknesses in at least 2 limbs developing 2 months or longer, and cranial nerves may be affected. Absent or reduced tendon reflexes in all extremities. Clinical inclusion criteria for CIDP variants are like predominantly distal, asymmetrical, focal, pure motor fuse. The exclusion criteria should be if the neuropathy is probably caused by Lyme's disease, diphtheria, or toxin exposure. If it is hereditary demyelinating neuropathy, prominent splinter disturbance, or IgM monoclonal gammopathy, or other demyelinating neuropathies. If the patient has these conditions, then we need to rule out that the patient has CIDP. Electrodiagnostic criteria, which we saw earlier. Supportive criteria should be elevated CSF protein, MRI, and ultrasound of peripheral nerve revealing enlargement. Abnormal sensory electrophysiological in any one nerve, showing normal sural with abnormal median nerves, or radial sensory nerve action potential amplitudes, conduction velocity less than 80%, and somatosensory nerve potential should be delayed without any cranial nerve system disease. And the patient should be improved with immunomodulatory treatment. And nerve biopsy should be evident of the demyelination and demyelination. The treatment of CIDP. Usually there are 3 treatment methods they give for the patients suffering with CIDP, which are IV immunoglobulin, plasma exchange, and glucocorticoids. If the patient is not improving with one of the treatment, then usually will change it to other others one within the 3 only. Like if all the treatments are failed, then we'll go to other treatments. IV immunoglobulin, it is usually given with the patient with severe CIDP, as it is easier to administer and it has faster response. Initial dose is 2 grams per kg, which is infused over 4 to 5 days, and it is repeat infusion of 1 gram per kg is given for every 3 weeks for 2 to 3 months. And we'll look for the duration of 3 months, how the patient is responding. If the patient is responding good, so, and this IV immunoglobulin has, if the patient is continued for longer time, and the response is good, he has higher chances of like remission of the disease. Adverse effects of IV immunoglobulin are headache, nausea, aseptic meningitis, and anaphylaxis, which is mostly seen in IgA deficient people. Acute renal failure mostly with sucrose containing products, hyperviscosity and thrombosis, plasma exchange. It is one of the effective treatments, but it is less convenient when compared to IV immunoglobulin, as the patient has to undergo multiple injections for that. It is usually given with in CIDP patients with severe disability for about 4 to 6 exchanges over 8 to 10 days. If the patient is improving well, then the exchanges are decreased to 1 exchange for every 3 to 4 weeks. Adverse effects are hypotension, sepsis, problems with IV access. As the patient has to undergo repeated venous access and catheters, he may have adverse effects like clotting and infections. Glucocorticoids. These are, it is usually given in patients with insidious onset of CIDP, as it is effective initial treatment. It is given either as pulse dose or daily dose in form of 1 to 1.5 milligrams per kg daily. Pulse dose as IV methylprednisolone 1000 mg per day for 3 days, followed by 1000 mg 1 day a week for 4 weeks. Oral dexamethasone is also given, like 40 mg for 4 consecutive days once a month, or oral prednisolone 600 mg once a week. Adverse effects are like similar to that of the patients who usually take glucocorticoids for longer times, like weight gain, cushingoid appearance, cataracts, aseptic necrosis of humeral head. Contraindications are peptic ulcer disease, brittle diabetes, refractory hypertension, severe osteoporosis, and systemic fungal infection. If the patient is not responsive to all the 3 treatment modalities, then they are given either cyclosporin, methotrexate, rituximab, cyclophosphamide, and even if the patient is not responsive to all those treatments, then in worst case scenario, the patient usually undergoes autologous hematopoietic stem cell transplantation. This is the treatment, the way, like the summary of all the things, like how we do. If the patient is diagnosed initially, we'll start with glucocorticoids, IV immunoglobulin, or plasma exchange. If the patient has shown improvement, then he'll undergo maintenance treatment. And if he is completely responsive, we'll start to taper the dose. And if he's having any partial or suboptimal response, then we'll again go back to increasing, or use any combination medications. Or as I mentioned earlier, if he's not responding well, then we'll move to other treatments. Okay. There are usually we'll find some special circumstances, like during pregnancy. In pregnancy, if the patient has patient with CIDP wants to get pregnant or is pregnant, glucocorticoids are frequently used as they are considered safe. Plasmapheresis can be considered, but we need to rule out any risk associated with that. IVIG, even though it's safe, but it has potential side effects that should be concerned regarding pregnancy. Prognosis. Usually, like we can see that in there is a retrospective review which is done with 106 patients for a duration of 6.4 years to know the prognosis of this disease. If the patients who have undergone 5 or more years of treatment were 11%, the patients who are like in less than 5 years of treatment are 20%. The patients who are still actively in disease, they are 44%, and improvement with the treatment modalities are 7%, and the patients who are unstable are 18%. Okay, thank you.